morning, everyone. We'll just make sure that everyone's been able to have a chance to jump in. So we'll just give it another minute while everyone slowly logs on in. So thank you everyone for attending and getting up early for this wonderful webinar this morning. My name's Shyla and I'm the CEO of Palliative Care Queensland, and we welcome you to join us today to learn more about paediatric palliative care. So on behalf of Palliative Care Queensland, we welcome you to the first statewide palliative care education morning for 2022. And this is such an important topic of paediatric palliative care. Often people think of palliative care as more around aged care and the elderly or older people, but paediatric palliative care is a big part of palliative care. So we often say palliative care is for every age and every stage, from in utero through to the geriatrics. So it's really important to focus on this topic too, and we're delighted to have some wonderful speakers. So I'd like to start by acknowledging the traditional owners of the land of wherever we are today and pay respect to elders past, present and emerging. And we extend that respect to Aboriginal and Torres Strait Islander people here today. I'm actually in Brisbane, which is on the Yagara and the Turrbal people's land, and I pay respect to our local landholders as well. Palliative Care Queensland believes that the way we care for our dying is a significant indicator of the kind of society that we are. Our organisational priorities are that all Queenslanders are able to live every day until their last, are able to have a dignified death regardless of illness, age, culture or location, have access to a supportive social network at the end phase of life, and the choice of quality palliative care. We'd like to acknowledge the sponsors and supporters for today's event. So PalCare Software is a sponsor for this event. PalCare is a secure web-based patient information management system used extensively throughout New Zealand and Australia. PalCare allows organisations to record and access client information in real time from multiple locations and by multiple disciplines. A web link for PalCare will be put up into the chat area, and you'll be able to see that as well in the email that we send you after. We'd also like to thank our other supporters, NQPHN for supporting us for this event through our Connecting End of Life Care in Townsville project, CELT-T, and also Brisbane South Primary Health Network for supporting us through our Palliative Brisbane South project, and also Ambulance Wish Queensland for providing the event complimentary to QAS paramedics as well. And this brings us to the housekeeping. For those of you who are unfamiliar with Zoom, I'd like to point out the following features that may be useful. If you hover your mouse over your button on the page, over your page, you'll see the number of functions, including chat and Q&A. Very aware some people might be on their phone or an iPad, and this might look different to different people depending on what platform you are. But you should be able to locate a chat function and a Q&A function as well. The chat function can be used to make comments or to give feedback in real time. Please ensure that you select the correct audience when you're sending a chat. For example, you can select panelists only or all attendees and panelists as well. To test this function, I'd love everyone just to jump onto their chat area now and to tell us where you are located today. So it can be the suburb or postcode, or it can be your local First Nations country that you're on. So for example, I'm here in Brisbane, in Spring Hill, and I'm on the Yagara and the Turrbal people's land. So it's lovely for everyone to get to know who's here when we can't meet virtually, but we can see each other. And thanks everyone for popping a lot of chat things in there now so we get to see all the different people. So and now to our panelists. I'm really delighted to share the wisdom and hear from these great people today. We have Anthony Herbert and we also have Peter Westerby. So I'll start by introducing you to our first speaker today, which is Associate Professor Anthony Herbert. He's the Director of Paediatric Palliative Care at Children's Health Queensland Hospital and Health Service, where he's worked since 2008. He is the group leader of the Paediatric Palliative Care and Supportive Research Group at the Queensland University of Technology. He's also the project lead for the national project Quacker, which relates to education in paediatric palliative care. He's been the chair of Paediatric Palliative Care Working Group of the Statewide Children and Youth Network since 2013, and a member of the Care at the End of Life Statewide Reference Group, now Care at the End of Life Collaborative. He's also a founding member of Queensland Specialist Palliative Care Directors Group, and he's also our acting president for Palliative Care Queensland. And many of you would know Anthony. He's been one of the driving forces of really improving and delivering excellent palliative care and for paediatrics, and ensuring paediatrics are really showcased at this time. So we'll start just by sharing a video that was recently featured in the Courier Mail. And I just must apologise first that it might be a bit low, the sound. So if it is a little bit low, then we will be sharing this, the link to this anyway after, but we will try and share it because it gives great context to what Andrew is going to talk about. So over to the video now. Thanks.
Hi, my name's Carissa Dunlop. My husband Cole and I have a 5-year-old son named Kyron. He has got a disease called Krabbe disease, which is a leukodystrophy. His disease is the infantile version, which is the most common of the Krabbe disease. And unfortunately for him, it's a terminal illness. Krabbe disease is what it is now. Krabbe disease is a breakdown of the nervous system, so the brain pretty much doesn't produce the right proteins to help support the myelin shield, which is the shield that looks after our nerves. So for Kyron, it means that he's on a world of medications, lots to keep him comfortable and lots to keep him from aspirating and from keeping out of hospital pretty much. So we do most of the work at home. And we do have a lot of teams behind us that help when we need it. There's been a lot of stress that's been put on our family because of this disease. It has been quite taxing on our other children. We've got 3 girls. The youngest 2 girls are still living at home, and there is a lot of change that has happened, but they have been quite gracious and able to. We work pretty well as a team. It does mean that we have to stop on certain certain times that we do things. However, we try and make up for the fact that we do go camping on a regular basis in the last, say, 24 months, and we have enjoyed a lot of family time. Being able to spend the time together has been probably the most important thing that we've learned from this disease. So Kyron's initial diagnosis was going to actually, they predicted was actually going to be about a year old, that he would pass away. However, we're very fortunate that he's just had his 5th birthday party, and we don't take any of those days for granted. We're very lucky because we've got some amazing support with not only family but friends, and not only friends but also medical world that is I think like second to none. Palliative care team, the metabolics team, and mostly important, the paediatric team at the Ecological Hospital.
It's Anthony here. I'll speak.
Our online classes and tutorials empower you to win on social media by giving you the knowledge you need. And our dashboard and calendar allow you to plan, schedule, and preview your posts across multiple.
I'll speak softly just in case you had to turn your microphone up to hear the video. So I'm giving you a little sort of a thumbnail sketch or a cook's tour of paediatric palliative care. Going to try and do this briefly so that we have time for discussion and questions at the end. I thought that case study was a good place to start, and I'll highlight some of the points from the story of Kyron and his mum Carissa that she so eloquently sort of outlined. But you hear about the stress on the family and I guess the care burden, particularly with these conditions that can that are degenerative but go for a number of years. And then the impact on the siblings as well. And then in amongst all of those challenges, you hear about a family that is living life and helping their son to live life through experiences such as camping, just enjoying time together, and also memory making as well. And you could see some of the images of the hand castings at the end there. So next slide, please. So there are various definitions of paediatric palliative care, but really it's a holistic approach, caring for children with a life-limiting illness, or sometimes we're now using the word serious illness, which aims to enhance the quality of life for the child and provide maximal support to the family. It's a very active and total process involving body, mind and spirit, and it begins at diagnosis and continues regardless of whether or not the child can receive other disease-modifying treatments. And the bereavement support's also really important. Next slide, please. So Maddie Stepanek was a young boy who's described as a poet who lived in America and died in the early 2000s. He had a chronic neuromuscular condition, and he described palliative care as no longer meaning helping children die well, means helping children and their families to live well, and then when the time is certain, to help them die gently. Next slide. So I guess just teasing this out a little bit more, it does require a team approach with the different professions: medical, nursing, allied health, chaplaincy, pastoral care, volunteers, school teachers, the broader community, and it can be successfully implemented sort of throughout the world. So, you know, in places such with less resources than Australia. And I think the interdisciplinary team is really critical, working in a coordinated way, trying to meet the needs of the family and to sort of help achieve the goals that they have. And obviously this care can be provided in hospitals such as the Queensland Children's Hospital, but all the other hospitals throughout Queensland and northern New South Wales. Clarissa mentioned Caboolture Hospital, the Children's Hospital, Hummingbird House, and in the child's home. And many of the principles and the philosophy of adult palliative care do apply to paediatrics. Next slide, please. This is just gives you a bit of an idea of the breakdown of ages. So this is where maybe the differences between adult and paediatrics occurs. You can see all the ages of childhood are represented, from neonates, infants, primary school, high school to young adults. And so that sort of developmental knowledge is really critical. And more than half of our patients have non-cancer conditions. Next slide, please. And so there are actually over 400 life-limiting conditions of childhood affecting neonates through to adolescence. And so you heard Carissa say, you know, Krabbe's disease, and there's only 20 children with that condition in Australia. So we're often dealing with rare conditions. Any organ system can be affected. So we have referrals from neurology, cardiology, oncology, metabolic services, and most of the specialties within the hospital. And so some conditions are associated with gradual deterioration in function that can occur over a number of years, again, as Carissa was describing. So really, in many aspects of paediatric palliative care, we're using the palliative approach as a way of providing chronic disease management to children and supporting their families. Next slide, please. So who are the members of our team? I sort of alluded to this, and I first started working at the Children's Hospital back in 2008, but obviously nursing staff, allied health staff, the bereavement service is really critical, chaplains, the research program, quality aspects, and also acknowledging the key role of volunteers. And New South Wales have got some really good work happening in that area. We've recently started, I think both Hummingbird House and Queensland Children's Hospital have started a peer support program for bereaved parents. Next slide, please. And this is a slide. This kind of is maybe a bit of a entree for what Peter will speak about, but you can see we have the child and family at the centre. We then have the supports in the community, which could be in Greater Brisbane, in one of the metropolitan areas such as Toowoomba or Sunshine Coast, or in a smaller centre such as Longreach or Emerald. But obviously we have our key colleagues in primary healthcare with general practitioners and community nurses, but also then also the specialist paediatric palliative care service available as well. But really just acknowledging the variety of healthcare supports available to families, but also acknowledging the non-professional support that families may be able to access, and also just acknowledging that there are some families where they may be struggling to tap into that support, whether it's because they've recently emigrated to Australia, an extended family, or in a different country, or there may be sort of cultural nuances for that family as well. Next slide, please. Your pain and symptom management is really key to what we do, and you might have heard Carissa say, Kyron's on medications around the clock to sort of keep him comfortable, and that itself is a care burden. But this slide just really shows you some of the key symptoms that we're managing in paediatrics: fatigue, pain, dyspnea, anxiety. And you can see that apart from fatigue, the blue bars have dropped from an initial survey done in the 1990s to another survey done in the 2000s in America. So you can see that we are improving in our ability to manage symptoms in children and to therefore reduce the suffering. Next slide, please. Another thing that we sometimes help families do is just helping them with complex decision making. So we do that in a shared way where the parents are obviously the expert of their child. Again, as Carissa so eloquently described, but we bring our own sort of professional expertise, and through a number of conversations, we try and sort of help families feel supported in their decisions, and whether treatments might be to prolong life or to give quality of life or to be solely focused on comfort. And that does often weigh up balance of benefits and burdens. The role of chemotherapy in a child with relapsed or progressive malignancy, or the role of spinal surgery in a child with a progressive scoliosis and respiratory failure. Next slide, please. Home-based care is really important. Obviously we have the hospital-based care and Hummingbird House, and Peter will give us a bit more of a description of Hummingbird House's model, both within the house but also extending beyond the house. But general practitioner, community staff, and I just acknowledge our non-government organisations such as Blue Care and Crooner and many others. Often there's hospital-based services such as hospital at home. There might be allied health staff going into the home. Equipment's really critical: hospital beds, mobility aids, bathroom equipment. Having some way of funding these things in a flexible and time-responsive way. Our staff can visit the people's homes, working alongside those other staff that may be supporting the family in the home. The 24-hour support is really critical, in the evening, on the weekends. And so we have developed a telephone support system that operates statewide in Queensland for both health professionals and the families. And short breaks or respite, so personal cares that can be done in the home or centre-based care away from the home, such as at the Children's Hospital, and just sort of acknowledging that planned, structured respite or short break can be something that sort of relieves the care burden for the families and is so critical. Next slide, please. And then obviously we're working in a state, and you can see Queensland is such a huge geographical size for our population, and so telehealth is so critical. And many of our patients are located outside of the southeast Queensland corner, and we're increasingly using telehealth to support families outside of the southeast Queensland corner. And also, I guess when we can, we will go and visit regional centres in Queensland to provide education and local support on an ad hoc basis. Next slide, please. So obviously I've mentioned the location of care. We often have a number of patients in the Children's Hospital. We partner very closely with the Children's Hospice, Hummingbird House, patients at home, and also acknowledging the hospital closest to home, whether that's Townsville Hospital, Emerald Hospital, located all throughout the state. Just one interesting observation, there were 35,000 children discharged from intensive care units in the UK, and if they received a palliative care consultation at the time of discharge, they were more likely to die at home or in a hospice or a non-PICU environment. So again, just acknowledging how some of the positive impacts of palliative care consultation. Next slide, please. Another work that we're doing is the Quacker Project, which is a national project where we try and provide education in an interprofessional way. You can see the team here out at Longreach. And so there was some members of the Paediatric Palliative Care Service, one member from Hummingbird House. This was a few years ago. And through our educational intervention, which is done in time and case-based, we're hoping that we can increase the confidence of local health professionals to manage a referral, to manage pain, other symptoms, to help the family prepare for their child who may die, giving medications, providing information. Next slide, please. So just other considerations, the benefit of establishing statewide networks involved in providing care to children with life-limiting conditions. And so we do have, there's a statewide child and youth network, and there's also the recent palliative care network. And I guess we saw the strength of the networks in the Senate in recent times with the ability to communicate within Queensland Health, but also externally to community partners such as Palliative Care Queensland. The importance of care post-death and bereavement support. Hopefully you'll see the benefits of a hospital-hospice partnership through today's presentation. I've briefly touched on the nuances of caring for those from culturally and linguistically diverse populations, or those from an Aboriginal or Torres Strait Islander backgrounds. Sorry for the spelling error. Research, how do we support ourselves and our teams working in this difficult area, and obviously ongoing support and professional development of staff, such as sessions this morning. And I think Shaila's going to mention the inaugural Paediatric Palliative Care Conference that's being held in October this year. Next slide, please. So just to summarise, there's the hospital consultation service adds an extra layer of support to patients, both during and after inpatient stays, and especially at the end of life. Other teams continue to provide their standard of care, such as the metabolic team and the Caboolture paediatric team, as in the case of Carissa. And I guess we try and value add with our expertise in relation to symptom management, communication, particularly around issues related to end-of-life care, care coordination, maximising home supports, after-hours support, planning for the location of care, and more broader advanced care planning. Next slide, please. So just a number of resources. I guess I'll just, the Green Book is actually being rewritten this year. So that's our sort of practical guide for health professionals. And so that's part of a broader sort of project called the Paediatric Project, which is sponsored by Palliative Care Australia and the Paediatric Palliative Care Australia New Zealand group. And so there's some work being done on a national paediatric palliative care strategy, organising the conference in October. So it's quite an exciting space, both working within Queensland, but also sort of the partnerships and the leadership that Palliative Care Australia is providing in paediatrics in terms of trying to coordinate direction forward and trying to maximise that cooperation between the states and the Commonwealth. So yeah, thank you for your time this morning.
Thank you so much, Anthony. It's wonderful to hear everything that you guys are up to, you and your team. It's doing an amazing job. The Quacker Project, which I've popped a link there in the chat, is a really outstanding Australian project that works really widely between specialist palliative care and generalists, healthcare workers, and everyone in the community around them. So I think it's a really standout project, and lots of interesting little take-home bits there and links for everyone to know about. There's lots happening in this space, so it's really impressive to see the growth in paediatric palliative care and great leaders like Anthony in the space. So I'd now like to introduce you to our second guest speaker, Peter Westenby. So Peter is a part-time community practitioner at Hummingbird House, a hospice for family and children with a life-limiting illness. We're very lucky in Queensland to have a hospice and our paediatric palliative care service, so it's great to have someone representing both to talk today. Peter is also the director and consultant at Community Praxis Co-op, a consulting and training organisation with a vision of more just, peaceful and sustainable community. He's the curator of the popular Pete's podcast on community development, as well as a visiting professor from the University of the Free State, South Africa, an honorary associate professor at Deakin University. He has written and co-written, edited many books, I think it's about 15 now, and over 55 professional journal articles on community development. He tells us that most importantly, he loves reading, walking, sitting by the fire under the moon or stars, wandering daily in the park, exploring his bioregion, being with friends, sipping coffee at dawn, and going to bed at 8:30 p.m. And he says, yes, he is a lark, not an owl. So we're delighted to have Peter. And I also just wanted to flag that we're really lucky in Queensland and with Hummingbird House and the paediatric palliative care community to be thinking out of the square and having community development workers as part of their organisation. So bringing that public health palliative care model to Queensland is really innovative. So it's great to be sharing what Peter's up to and to hear from Peter himself. So I hand over to you now, Peter.
Thanks, everyone. And I'm speaking from Maleny, Jinnaburra country. It's pouring with rain. It's thick with cloud. So I hope the internet works okay. So yeah, I'm a non-medical practitioner, and I assume everyone who's here today is some kind of medical generalist or specialist expertise. And I guess part of what I'm adding to what Anthony has given is like that delicate relationship between the absolutely essential medical expertise and yet the reality that 95% of people's lives are spent in community and at home, and what's that place in this work. So, I'm just going to tell a bit of some of the community development component. But if we move to the next slide, just so that people do understand, we won't go to the link, but it is, as Shyla said, Queensland's only children's hospice and only one of 3 in Australia. And that's a big brief in such a huge state. It's 5 years old in terms of the building that we have at Chermside, and 10 years old in terms of the dream that was initiated by a family who had a child with a life-limiting illness. So it was their dream to start Hummingbird House. Next slide, please. It's a very beautiful building in Chermside that is the kind of heart of the work. I've put here, we've got 3 teams, but we're trying to do more and more work beyond the house. The house is in Chermside, and it's a award-winning designed building with 8 suites where families, children can be. They're very beautifully designed. They've got a lot of the medical technology, but you wouldn't even know it's there. It's hidden behind beautiful kind of carpentry. And so people are in a hospital, kind of non-hospital like medically sound setting. And we have a clinical team, 24 hours, 7 days a week, nursing staff, allied health. After death care, we care for children's bodies when they've died and support families in the grief mourning work. We do end of life care in the last days where people who decide they would like their child not to die in a hospital nor at home, but have this other third option of a hospice where you've got medical care, but it's not a hospital-like setting. And we do respite. We have families staying every day of the week, every week of the year. Emergency symptom management, visiting the children's hospital. But increasingly, we have this second team, Hummingbird at Home, that spend time with families in their community, supporting their paediatric palliative care needs, symptom management, etc. And then we have this third team that I am a part of, family and community support team. So we're really doing the family social workers, bereavement, sort of advocacy, and the community team, which is 2 of us. Now, I just want to say, we've been listening to families for a long time, as would Anthony's work. And along with the medical travesties that people are living with, social isolation is the key issue in people's lives. As families who have a child with life-limiting illness grapple with what they have described as the medicalization of their life just becomes super dominated by the medical world, which makes sense. There's huge medical needs. And increasingly what we call the NDIS, bureaucratization of their lives. Their kind of world shrinks and they lose community. So part of our work as the community team is to support the community dimension. So just the next slide, I'll just kind of give you a sense of some of like what this means historically, and Shyla and Anthony would be very big on this too, the global and national trends. This beautiful quote, dying was once considered a social and community event. However, over the last 50 years or so, dying and death have become medicalized life events. And that's true. You know, and as the second point says, this has led to many improved services, and it's fantastic we can manage the symptoms and pain of children, that we can keep children living longer lives, as that beautiful video suggested. The mother, they're having more years than they expected. So, you know, navigating death, dying, palliative has become the province of the expert. But we are seeing globally a return to the social or community. If you could move to the next slide. And that is that people there's this move away from the individualized, medicalized, service-only provision to more of a, how can the medical profession partner delicately families where they have more choices? How do we, as the medical profession, not assume there is a right way or the best way, but really work with people's, families' choices, how to die, where to die, what's the role of community? Are we involving community in the decisions? So if you move to the next slide, just a couple more. Just so you know, when we're talking about community development in the palliative or paediatric palliative care space, we're not just making up new things. There's a lot of research, and the HELP framework here from La Trobe University really outlines a great framework of how we can, you know, have clear principles where we promote death and grief as a natural part of life. We promote the collaborative culture for community support individual and community, healthy end-of-life planning, and on and on. And I just want to, those last 2 points, changing social norms, are so crucial. We live in a culture where people, we know from the research, want to support families who have children who are dying, but they don't know how to offer support. And we have families who want to ask for help, but in a culture where we don't really know how to ask for help from our neighbours, from our relatives. So part of my work is, how do we support communities to become what we call more death literate, grief literate. So for example, one of our partners is the Calandra Community Centre on the Sunshine Coast. And with them, we're not only supporting families on the Sunshine Coast that they can support social networks that are understanding of their grief and their difficult lives. But we're also running community events with 20 to 30 people who come along, where we learn about how to be grief literate and not avoid grief. What does it mean to accompany a family with children who are grieving? So these are people that say, I want to be a good neighbour, I want to be a good citizen, but I don't quite know how to do that. So community development work is doing that. Just the next slide, thanks. So our work at Hummingbird House in this space is really focused on these themes. One, how do we support the informal networks in people's lives, in recognition that 95% of their life is spent at home, and the informal networks with neighbours, the people that might come and mow the lawn, people that could help them shop, the pharmacist. How strong are those networks? Because when you're in a crisis, those networks matter. Obviously, how the service providers, professionals interact with those networks, not always assuming the best response is a service response, but the best response could be supporting the informal networks. With the theme 3 is this literacy, death literacy we're doing in communities. The 4th is how do we support other systems in community, like faith-based institutions, the neighbours, schools, to be more understanding. And then we are interested in place, because place is where people spend their lives. And, you know, if people get isolated in their homes, but they aren't, you know, not accessing the healing potential of nature, that's a big loss. And the link there to Groundswell is a kind of global movement, the Groundswell project, that's really in sort of exploring this. I'm just aware of time. Shaila, how much time do we have before we want to go to Q&A? Because it's really
continue.
Yeah, for a few more minutes.
Sure.
Yeah. So if you go to the next slide, just at Hummingbird House, I think I hope you can read them. I can, because I've got my reading glasses on. So in our community development work, that first image is community development is a way of linking need to resource via natural or organic or social networks. And what this really means is, in professional service delivery, the need is met by the professional. We are the resource. But in community development, we recognize that if people have good social networks, they can often find the resource in the network. So, you know, if somebody needs someone to help them with shopping, if you've got a network, you can ring a friend and they'll come and help you. If you haven't got that social network, you have to end up ringing the professionals, or you end up not ringing anyone and nothing happens. So this is the power of community. Community is social networks. So our job is to rebuild them. At Hummingbird House now, when we do our early holistic assessment with a family, we very carefully spend a couple of hours with the family, not only exploring what are your goals and aspirations, but what is your social network like? Where is it functioning well? Where would you like to see it functioning better, so that we can work not just to support the family, but support the network? So that's really important. And this network understanding of community, don't think of community as a thing, think of community as social networks. And in our paediatric palliative care work with a family, always be curious about the networks, the friends, the aunties, the grandparents, the siblings. Don't just think of the family unit, think of the family unit in their context, because that's the network that will be there for the 95%. And particularly when a child dies and bereavement takes over, although bereavement would have started a lot earlier, the professional services will withdraw and people are left with no support unless they have a social network. And as people move into the bereavement part of a child's passing away, they're really going to need that. So if we move to the next slide, this is really thinking ecologically, an ecological thinking approach. Community development always recognizes that you've got the central person, the child. We focused on that person, the family, the neighbors, the groups, the schools, and the services are at the outer edge. So the key is to remember that sometimes our work as a service is not to best work just with the child, but building the capacity, the capabilities of the other parts of the network. So, you know, we're doing work in partnership with organizations in schools. We're doing work with neighborhood centers that already have good social networks that can support families. And I think I'm pretty well on my last slide, the next one. I just want to emphasize, if you interact with someone like myself, the community development worker, we very much avoid the language of helping, and we recognize service providers want to provide help, but we tend to use the language of ally, solidarity, accompanying. So for example, I'm working with a group of 4 or 5 families in the Bundaberg region that are linked to the Children's Hospital Palliative Care Unit and Hummingbird House. I've been working with those families so they meet one another and support one another, and it's fantastic work. But I never said, I'm going to come to Bundaberg and help you. I worked with one family and said, I'm willing to accompany you in us building a network of families. Do you want to do that with me? And she said, that'd be great. I want to have better networks. So we worked together. I didn't help her. I worked alongside her. So that's really important. And the last point there, within community development, people go, well, what is this thing called development? Well, at the heart of the idea is development is that people have power, that they have choices. If you don't, community development's aspiration is that people feel they have more choices in their lives. And so really that is my ultimate goal. Even the hospice idea is, you know, you have a lot more options than you probably think as your child is moved into palliative care. And then you need to think about a funeral, for example. A lot of families don't even know what their options are, and we can support and accompany them in making more choices. So that's really all I've got to say, a very non-medical angle on this wonderful world of supporting and working alongside families. Thank you.
Thank you so much, Peter, for sharing your different view in this space. I think it's so important to have these different perspectives and handy lessons learned. I think we often say helping. I think my background's a nurse and I think we love to help. And so I think those lessons are really great. The importance of language, which someone's put up in the notes, is really critical. And thinking differently about this, it's working with people in that space, it's working with their community, and also valuing the amount of assets there are in communities and how we work with them in that space. And I think we also learn so much from everyone as an individual, and so it's that collaborative learning which is so important. So thank you so much. Lots of little little great quotes there. I really love the fact that language of their world shrinks and they lose their community. I think that's such a good description that often happens. Some people, it's the opposite, almost their community grows. But I know, having been a paediatric palliative care nurse, I remember I used to say it's one of the biggest conversation stoppers in a pub, because people just, you know, palliative care is hard to talk about, but pediatrics is another layer for a lot of people. So the way that both you and Anthony are working in this space to really open up discussions and normalize that this happens, and that if we can work with people, it's a really critical way to help and support them. Sorry, not help, but yes, support people in that space.
I have no problem with nursing and medical professionals using the word help. It's just to recognise in my work we use different language. You know, it's it's just different. Yeah.
And support is a great word, I think, in that space. There's a lot there.
Yeah.
So just everyone, now we'll move to a Q&A. So I can see already a couple of questions, which I'll start by asking our two wonderful speakers. You can just pop them in the Q&A area so you can see them there, or you can pop them in the chat as well. Either way is absolutely fine. So I might start with our first question here and ask Anthony, so are you able to comment on advanced care planning used in the paediatric palliative care space? What's the uptake like, and attitudes in having formal documentation in this space?
It's a very good question, and thank you for that. It's an area that we've got increasing focus on with a few different elements and streams. Firstly, it's a series of conversations, and it can't be forced. It has to sort of come out of meeting the family and sort of being curious about who they are, as Peter said, doing a lot of listening. And then out of that, the family's goals evolve and the advanced care plan will crystallize. Not all families will want an advanced care plan, so but many of the families do. And for example, Carissa, who's presented in the case study, I've had quite detailed conversations about her wishes for Kyron, to the point that we know that she'd either want him to sadly die at either home or Caboolture Hospital, but would like to go to Hummingbird House for after-death care. So I guess we're sort of thinking about how that would look mapped out. In terms of the tools we've got, we have been working on a paediatric statement of choices. So similar to statement of choices with a few modifications. That took a few years of development, and the lawyers had their sort of input onto that as well. Now that can be uploaded into the ACP tracker, and so people in emergency departments and at other hospitals can see those documents. This work's still in evolution, but we can actually track the number of conversations, and the actual document can be loaded up. So pediatric statement of choices, with some of our children being very young or non-verbal, so needing their parents to be their proxy or substitute decision maker, and obviously the older adolescent who's got cognitive capacity, having some, it's important that their voice is heard. We also have another exciting program called Voicing My Choices, which is an American evidence-based sort of program, and one of my colleagues in New South Wales, Ursula Sampson-Daly, has been doing work on this for a number of years, and we've actually developed an Australian version of Voicing My Choices for adolescents. It's quite an exciting document. It's very Australian. It has a bucket list page, and we're just at the stage of implementing it with, say, 10 or so families and doing an evaluation on is it helpful. Because we often come up with these ideas of what we think might be helpful, but until we sort of evaluate it and maybe get the family's perspective, we don't fully know. So that's an exciting one. I know Hummingbird House use another sort of tool called Hopes and Wishes, and so I guess that's that principle of addressing fears, but also embracing hope and trying to work out what the family are hoping for. And sometimes we have to sort of reframe hope as well, or readjust goals to keep moving forward.
Thank you so much, Anthony. Lots going on in this space, isn't there? It's really interesting, and I like the innovation that happens and sharing international tools and adapting them locally. And I think learning from pediatric space for adults is also really great. So thank you for sharing that. I'll ask the next one over to Peter. So Carolyn asks about, for a CD, from a community development perspective, do you have any end-of-life doulas involved in the care trajectory? I'll just add here just a bit of an update from a national perspective in the end-of-life doula space. So Palliative Care Queensland is working with Palliative Care Australia and all the other jurisdictional peak palliative care bodies in the end-of-life doula space, with the aim of developing a position statement in this area, because we are aware that there's such a variety of skill sets, education and backgrounds to end-of-life doulas, and also that money is exchanged as part of that. So we have been looking into that space. We're working with Flinders University, who have done quite a lot of research in this area. So if you're interested in the end-of-life doula space, please look at the Flinders University journal articles in that space. And we've hosted a national roundtable with the palliative care peak bodies and a number of death doulas and key death doulas that are leading education programs as well, to collaboratively work together for the future in here. So it's still just it's a work in progress area, but there's a bit of work being done in the strategy and policy space of the end-of-life doulas, which will keep you up to date with the Palliative Care Queensland. But I'll pass over to you now, Peter, to talk about this specifically in the care trajectory space.
We've not directly partnered with any particular death doulas at Hummingbird House. That's not to say families themselves might not have engaged with death doulas. And much like Shaila's saying, we're kind of curious where national statements or standards emerge. Mind you, our last community conversation or compassionate community conversation on the Sunshine Coast in partnership with Calandra Community Centre, which had about 30 local people. We had 2 people present, which the community requested. One was a 61-year-old man dying of cancer who had decided not to go on with his treatment, wanted to share about his advanced planning process. And the second one was a death doula come to explain to community members what a death doula does, and that was really informative. So I think there's a lot of people in community interested in what death doulas do, and this is indicative of this community turn. You know, like, how does community have some kind of more of a knowledge, skills in this space? So that's probably all I can say, Shaila. Yeah, very curious what the national statement standards might say.
Yeah, no, it's an exciting area, and I think it shows the diversity in palliative care and different interests and everything in that space. So I think it's a really important discussions going on lots of angles, very inclusive, very consultation process, and also evidence-based as well. So great having the university behind it. So yeah, looking up, just flagging, so it's mainly Deb Rawlings from Flinders University. So if people are looking for journal articles in that space, there are probably on Care Search site, but also you could Google Deb Rawlings and find her articles as well. I know Joe's mentioned a comment there for Peter, so Peter will connect with you, Joe, just regarding that specific place, so that you'll be aware of where it is in the sunny coast. Lovely. And there's lots of chats just going on in the chat area. If people want to see any answers there, you can see Anthony and Peter responding to them, which is great. So I guess just to wrap up really in this space before I close everything, it's the Peter and Anthony, if there's one thing that you'd like to share with everyone, it's very hard to say one thing, isn't it, when so much is going on, but just a little word of wisdom or something you've learned, I guess, in this space that you think might be nice for a bit of a take-home message for everyone. If you can think of one of them, would be great. I'll start with you, Anthony.
Yeah, well, just something that was crystallizing in my mind just now was that sort of idea of be curious and be careful of the language we use, and don't be scared of silence, to allow space for the family to sort of initiate the conversation. And I see Julie says spiritual care workers are quite natural doulas. And I think if we watch what's happening in the family network with curiosity, I remember one family from the Sunshine Coast who were going through a really tough time, and the child had quite a different spirituality to their parents, and their local school chaplain was quite a critical person to the support of that family, and that was quite independent of anything from the hospital or from any sort of church affiliation. So just, yeah.
Wonderful, thanks. Over to you, Peter.
Wow. I've worked in many community development spaces around the world over 30 years. And I think the two things that this work, which is quite new to me, 2 to 3 years, is one, that you kind of need to develop a grief practice to work in this space, that grief is a normal everyday part of life. And if you're going to accompany people living with a child who's life limiting, grief is part of their world. And if we're going to support and accompany, we need to be very okay with grief. And I remember when I was on an interview panel for someone at Hummingbird House, and my team leader, Ellen Day, asked the person in applying, "What's your relationship to grief?" And the person kind of looked stumped. It's like, that they didn't have a relationship with grief. Grief was a stranger. And I think I just would say that the wisdom is we need to develop a grief practice, and that is not turn away, welcome, embrace, learn about grief. Because then we can stand in the silence that Anthony just mentioned. We don't need to fill it with words because of our own avoidance. And, as Shyla started this session, many people think of palliative care as adults and old people, but we're increasingly advocating for the lifespan or intergenerational approach so that we're really inclusive of families that have children who are dying. So that's it.
Absolutely beautiful from both of you. I think that's such a synergy between both your messages. It's really just delightful to see how everyone's working together in this space and really sees the bigger picture and everything there. Just also recognising for everyone that paediatric palliative care can be really difficult to talk about. And so really, for everyone that's online today, just to also look after yourself and take some space if you need it, just to reflect on the discussions. I think, this is a normal part of life, but it can be tricky, particularly in the paediatric space. So we recognise that as well. There's a couple of notes going up there around Catherine Mannix's beautiful books and work as well, and there's so much great work out there. So really just keep the knowledge going, and really encourage you guys to think more about this space and do that grief work and self-reflective practice as well, so that we can be able to stand in the silence, as you guys so beautifully eloquently said. So just to wrap up now, obviously a huge thank you to both Peter and Anthony today about sharing their wisdom and their knowledge and experiences with us all. It's just such a delight to hear and to learn from. Also, thanks to the team that are behind the scenes, moving on the slides, organising the meetings and everything there, Brendan, and also to James and the other team members as well. Thank you all so much. Thank you to our sponsors and supporters for this event. So Power Care Software, NQPHN, Brisbane South PHN and Ambulance Wish Queensland. We can't hold these events without the delightful support of our members. So really encourage you to consider becoming a member of Palliative Care Queensland. If you work in health or in this space, you might be able to get it as a tax deduction as well. So we try to keep the membership prices really low, but we are a members-based community health professional organisation. So we really encourage everyone to become members if you can. And there's details there on the screen. You'll receive an email after this event just with information about sharing some of the slides, but also links that we've said, and also an evaluation. I know everyone's so busy at the moment, but we really encourage you to complete that evaluation. It really helps us to grow and learn ourselves and to improve these events in the future and choose future topics as well. If you'd like to request a certificate of attendance for this event, for your professional development records or other reasons, please email us at events@palliativecarequeensland.org.au. And again, that will be in the email after. Anthony and I both mentioned the Paediatric Palliative Care Australia Conference, which is the inaugural conference this year in October. So the details are there. So if you're interested in this space, we encourage you to get involved and share that with other people. We'll also make this webinar available for the next 3 months or so online on our YouTube channel for people to be able to watch. We'll send you the link to that, and we encourage you to share it with other people as well. So what's coming up next? Let's have a look. So we've got our community statewide education webinar on Wednesday, the 23rd of March, which is about what matters most. And it just happens that that topic is in National Advanced Care Planning Week as well. So I encourage you to get involved and share that throughout your networks. Our next sector education webinar is scheduled for the 25th of May, and it's on palliative care needs for First Nations people. And again, that one's in National Palliative Care Week, so we've timed them quite well. So keep an eye on our website for future events and details, and just thank you everyone and have an absolutely beautiful day. Thank you again. Bye.